Hi, I'm Daniel Zetter, a fourth-year student here at the U of L School of Medicine. Today I'll be presenting a clinical vignette on the characteristics of multiple myeloma in the acute setting. Learning objectives for this presentation are focused around emphasizing the importance of early diagnosis and treatment of multiple myeloma, prognostic indicators in the acute setting, and a general treatment strategy for these patients. Our patient is a 46-year-old male with a history of recently diagnosed IgG lambda multiple myeloma and very minimal routine primary care. He was seen in an outside hospital a month prior with serum protein electrophoresis, free light chain analysis, and serum immunofixation significant for elevated M protein, lambda free light chains, and IgG. He was started on triple therapy with cyclophosphamide, bortezomib, and dexamethasone for his myeloma at this point, with completion of one cycle before he left against medical advice. A month later, he presented with confusion, fatigue, epistaxis, oral mucosal bleeding, and an ecchymotic rash on the chest and lower extremities. Vitals showed he was tachycardic and tachypnic at this point, and initial labs indicated he had anemia, thrombocytopenia, leukocytosis, hyponatremia, hypercalcemia, and elevated creatinine and lactic acidosis. Chest X-ray and image A showed multifocal pneumonia of the right upper and middle lobes, and he was started on broad-spectrum antibiotics and IV fluids with plans to continue his myeloma-directed therapy once stable. He required intubation and sedation shortly after admission, and repeat myeloma labs showed further elevation of the M protein, IgG, and lambda F free light chains. By day 5 of hospitalization, he had required 3 units of packed red blood cells and had been started on a norepinephrine drip. CT scan shown in images B and C showed extensive osteolytic lesions and hepatosplenomegaly. His labs had showed some improvement to this point. However, by day 7, he was requiring an additional vasopressor, and labs had begun to indicate that he had developed diffuse intravascular coagulation, tumor lysis syndrome, and acute plasmacytic leukemia. Further interventions were deferred in place of comfort care at this point, and the patient passed shortly after. This case highlights the severity of myeloma in acute settings and the importance of early diagnosis and treatment. This patient likely had initial onset of symptoms many months prior to this diagnosis, which was unrecognized due to the lack of primary care. Maintaining a high suspicion for myeloma in these patients with nonspecific findings like anemia, bone pain, fatigue, and calcium or creatinine abnormalities is vital, as delayed diagnosis from initial onset of these symptoms increases the risk of acute complications. Many of the presenting findings our patient had are associated with early mortality and poor outcomes. Hematopoietic dysfunction, such as the anemia and thrombocytopenia seen here, is correlated directly with early mortality, and the classic myeloma findings like hypercalcemia, extensive osteolytic lesions, and renal dysfunction in this case are also associated with poor clinical outcomes. Bacterial infection secondary to the underlying immunocompromised state of untreated myeloma patients is the cause of up to 50% of cases of early mortality for these multiple myeloma patients. Secondary acute plasmacytic leukemia is a rare and often terminal event that was diagnosed in this patient, with the findings of the newly circulating plasma cells and hepatosplenomegaly pointing towards its diagnosis. Management of these patients requires keeping both their underlying disease and acute complications in mind. For patients like ours, early initiation of broad-spectrum antibiotics and IV fluids was critical for treating sepsis from the bacterial infection, which is most often due to underlying pneumonia. Packed red blood cells and platelet transfusions can also be used to manage the hematopoietic dysfunction, but as in our case, may be required multiple times and may be refractory. Calcitonin and bisphosphonates can also help treat hypercalcemia seen in this setting. And finally, initiation of myeloma-directed therapy should be deferred until after the patient has been stabilized and a workup for stem cell transplant candidacy has been performed. Thank you.